How to minimize the therapeutic failure in infectious diseases. Here, clinical microbiology perspectives. What is therapeutic failure? Failure to accomplish the goals of treatment resulting from inadequate to inappropriate drug therapy, and which is not related to the natural progression of the disease. The detection of treatment failure is mostly based on the objective clinical criteria. Less well-defined subjective decisions of the treating physicians also can made. So parameters, what we consider under criteria, clinical criteria, parameters are symptoms such as death, failure, persistent fever with the therapy, or hypothermia going into sepsis, respiratory rate which is more than 25 cycles per minute, increased heart rate, or hypotension, altered mental status with or without organ dysfunction, acute respiratory failure, hypotension, septic shock, multiple organ dysfunction syndrome. Treatment, additional antibiotic or change of the regime, admission to intensive care units, need for vasopressors like drugs, including inotropes, need of mechanical ventilations, and need for reoperation. Laboratory-wise, in vitro resistance originated, persistent infection, leukocytosis, neutrophils, blood urea nitrogen rise, C-reactive protein procalcitonin, radiological progression of radiological images, new pleural effusion or progression of opacification or cavitations. So therapeutic failure, what is it? Even with the proper medication, there are associated failures. Is it due to non-responders to drug? So it's time to think. Anyway, what are the reasons? We know disease triad. Host, pathogen is there, and associated environment is there. So this is disease triad. So here the interface is host parasite interactions and pathogen with other microbes, microbial interaction with the host environment, pathogen environment. Likewise, it is three-dimensional, even multidimensional. So about host, immune status of the host. If immunity is good, failure is less. Comorbidities such as obesity, who having diabetes mellitus or any other metabolic disorders, organ dysfunction, associated ICU high dependence unit support. Patient is bedridden, immobilized. So natural defense system is affected. Having invasive devices, patient is at a risk of acquiring diseases as well as failure. Fluid redistribution associated with volume of distribution changes due to sepsis or any other organ dysfunction following surgery, metabolism, very microbiome commences, and sepsis. Micro pathogen, that is term bug, microbial biomass, virulence about the organisms, speciation, antimicrobial susceptibility, superinfection, antimicrobial resistance, as well as biofilm. If we are not providing biofilm eradicating therapy, patient may get or acquire disease and therapeutic failure is high. Antimicrobial resistance, that's the other thing. Having dual infection or added infection, secondary infection, likewise. About the drug, it could be drug related or practice related. Drug related, so it includes product, drug potency, drug interactions. About the product, active pharmaceutical ingredient and excipient. It is the one which the active one, and there are excipient like base stabilizers. So there may be excipient may cause in the reactions. Likewise, about practice related, appropriate timing. It is very much important. Use of appropriate antibiotic. About empiric data on how to initiate the target therapy, dose optimization. So practice related further elaboration, escalation or de-escalation. These are very much appealing terms. Later on with IV to oral switch, that is more often responded, drug level monitoring, adverse effect monitoring, all are very much important. So anyway, key is etiological diagnosis. Is it bacterial? Is it fungal? Is it viral? Is it parasitic? Parasitic? Is it prion? Likewise. So diagnosis is the key. Once we know the diagnosis, we can give the target therapy. Until such, we are in empiric stage. About practice related, drug, appropriate timing. It is very much important. Here you can see as early as possible, because there are delays, type of delays, patient delay. Patient may stay at home, not coming on time, because that's how it's in like third world countries, even in developed countries, people may wait or go for the GPs. GP may treat, but if it is a risky case or specialized case, patient's delay is very much appealing. Medical practitioners delay about the diagnosis and treatment delay. Even we have diagnosed, there may be status where treatment delay. So it's time critical, like sepsis, bacterial meningitis, febrile neutropenia. We have to treat on time. Door to needle time should be less than 1 hour in sepsis, because it's a medical emergency about related about sepsis. Patient survival rate with the time initiation of antibiotic, you can see this chart. At the beginning, it is 80 or 82, 83% like, but in 1 hour, it goes down 7% like every hour. With the delay, mortality is increasing, no survival is decreasing around 7% like. So this is very much important about the identification of the sepsis. So clinical vigilance, open-minded, and always think, is this sepsis? So there are criteria, and in clinical plus there are scores. News is an aggregate score made up of 6 physiological parameters: respiratory rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness, and temperature. So if news score, early warning score is more than or equal 5, presence of unknown infections, sign or symptoms of infection, who are at elevated risk of infection. So often frequent monitoring, half an hourly monitoring is very much important. If score is rising, it implies impending sepsis. There are others like NICE guideline, NG51, then quick QSOFA, sequential organ dysfunction failure assessment score. There are term QX calculator. So QSOFA, respiratory rate, we give a value. Systolic blood pressure, if less than 100, it is 1 given as denoted. Altered GCS more than or 2, mortality is 10%. So screening for outcome rather than the diagnosis. This is the other way we are using. Appropriate timing. Soon after taking appropriate cultures specimen. Without waiting, we have to initiate. Like in febrile neutropenia, meningitis, even patient comes with fever, we have to take blood cultures, minimum 2, then start empiric antibiotic. But there are some instances like subacute bacterial endocarditis, vertebral osteomyelitis, discitis. We can wait because patient is not such ill. Patient may be stable. Time to time, patient may be getting associated symptoms with fever. So we can wait. take samples and arrive at definitive microbiological diagnosis. Then we can give targeted therapy rather giving empiric antibiotic. So it is a rational approach as well as it will be helpful to antimicrobial stewardship. So use of appropriate antibiotic. So appropriate antibiotic mainly lies with empiric therapy. This must be appropriate. So how we select? So depends on diagnosis. Clinical diagnosis initial, is it viral or bacterial? So there are, as I said, inflammatory markers, CRP, procalcitonin will be helpful. But with the implementation of the rapid diagnostic, it would rule out. It will be helpful, and then we obtain until ABSTO, if it is viral, we don't want. If it is utterly required for specific diseases, otherwise we don't opt antibiotics. About the clinical history, is it community acquired or hospital acquired or nosocomial in origin? So thorough clinical history is very much important. So nosocomial, what is 48 hours after admission of patient develops symptoms. So then site of infection. So probable micro. We have to think if it is pneumonia, if it is community acquired, common pneumococcal, streptococcus pneumonia, Haemophilus influenzae associated with other atypical Mycoplasma legionella chlamydia species. If it is hospital acquired pneumonia, it could be Pseudomonas species, so methicillin susceptible or resistant Staph aureus. Or if it is ventilator associated pneumonia, we think is it Acinetobacter, Pseudomonas, so again MSS or MRSA. So site of infection, clinical history are very much important. Similar cellulitis, community acquired, hospital acquired. We often not classify as such, but often cellulitis presented as community acquired. But there may be clinical history. So common MSSA, MRSA, and strep pyogenes. Infective endocarditis, it is acute to subacute. Is it native valve or prosthesis? It is right-sided or left-sided. UTI, community acquired or hospital acquired, or associated with use of catheter. If we think hospital acquired or community acquired, more often E. coli is the most common. But if it is community acquired, it could be susceptible one. But if it is hospital acquired or patient catheterized patient, often it associated with multi-drug resistant variety. So to decide empiric therapy, we need local epidemiology data. At the moment, there is scanty. So MRSA. So it's a study done by our team. During the 18-month period, there were 1,300 and 260 blood cultures were investigated for possible bacteremia. We found 4.5% of MRSA. HMRSA hospital-acquired bacteremia was 3.03. It's high. About the ESBL, about carbapenem-resistant enterobacteria, vancomycin-resistant enterococci, vancomycin intermediate or vancomycin resistant step. It's luckily in Sri Lanka it is state 3.0. So to decide apart from those mentioned factors, we need to do local epidemiological data. About the previous colonization, knowledge of bacteria known to colonize a given patient, screening nasal swab, awaiting prosthesis implant or coronary artery bypass granted, CABG. So we often do MRSA screening prior to that. About the vancomycin resistant enterococci, carbapenem resistant enterobacteriaceae, we don't know the rates. Inadequate therapy for infection in critically ill associated with poor outcomes. Broad spectrum antimicrobial agents as initial empiric therapies advised. Combined therapy. Commit pneumonia. If you often commit acquired pneumonia, we give beta-lactams with macrolides. Like febrile neutropenia, we offer piperacillin tazobactam, beta-lactamase inhibitor combination with aminoglycosides. who suspecting Pseudomonas cava. Often our aim should be avoid double beta-lactam therapy except if patient suspecting Listeria monocytogen meningitis. We often give ceftriaxone with ampicillin or double beta-lactam, carbapenem resistant. Then we often double carbapenem therapy, meropenem with ertapenem, meropenem with imipenem. Or otherwise, there are high level gentamicin resistant enterococci. We often give ceftriaxone with ampicillin rather giving ceftriaxone alone because it is enterococci are inherently resistant to third generation cephalosporin. Also, use of multidisciplinary association of supportive care for cancer is called mask score for febrile neutropenia. If it is less than 21, high risk. If it is more than 21, low risk. Likewise, we often do. Then how to target? Once culture with susceptibility report is available, we can go for narrow spectrum. It depends, okay. Reduce cost, toxicity, and prevent the emergence of antimicrobial resistance in the community. We can straight away narrow and give the targeted therapy. Dose, it's other aspect. Weight-based formula we use often. Then appropriate frequency. Likewise, ceftizidime 8 hourly, ciprofloxacin 12 hourly, except Pseudomonas bacteremia. We give 8 hourly. Ceftriaxone for infective endocarditis can give as daily. Appropriate duration. Infective endocarditis, right? Often with right side, uncomplicated, we can give 14 days. If it is left, often we give 28 days. Melioidosis, bacteremia, we give initial therapy 14 days. With focus, we often give 21 days with meropenem. Then cons- consolidation, we give 3 months like septic arthritis, initial intravenous, followed with oral osteomyelitis as such, maybe 6 weeks. Bacteremia, maybe 10 to 14 days. Pneumonia, 7 days, likewise. Dose optimization is very much important. If we can calculate minimal inhibitory concentration, that is an asset. Other thing is based on hepatic and renal function, calculation of expected GFR and also hepatic function assessment to reduce the nephrotoxicity, like aminoglycoside, glycopeptides. If we use few days, patient having reduction of expected GFR or rise of serum creatinine, we have to optimize the dose. Perhaps maybe reduce, maybe go for the alternative options to reduce the accumulation, like beta lactams and quinolones. It tend to accumulate. And tigecycline in moderate hepatic impairment, we have to optimize. High dose toxicity, that is other one dose. If we give higher dose, toxicity. If low dose treatment failure and emergence of antimicrobial resistance is high. So dose optimization is very much important. Other term about escalation and de-escalation or streamline, we overall say, can decide on clinical response and markers of inflammation. That's why always we often do CRP in baseline, procalcitonin in baseline, then CRP in 48 hourly, while PCT we can do daily, but it's costly test. But sensitivity and specificity is high. If we see this receiver observer characteristic curve or rock curve, you can see in green line procalcitonin, it is sensitivity of 1 minus specificity is high. So its area under the curve is high compared to the CRP. So it is also we can use as a daily test. So escalation or de-escalation, perhaps streamline. So we can as policy initiate with broad spectrum and later de-escalate, or maybe vice versa. It depends. The most common mistake made with apparent antibiotic failure is to change or add antibiotics irrationally. That's the case. So de-escalation therapy, empiric therapy, early therapy, broad spectrum agents, consider combination therapy, optimization of dose schedule, then appropriate cultures, blood, site of infection, then streamlining of empiric therapy. Stopping agents with go for the narrow spectrum, low impact of microbiota, optimization of dose schedule, use of oral route if possible, consider cost. So overall, it depends individually. If patient is responding, we can de-escalate or going hierarchically down. If it is patient is not responding, we have to escalate, adding. That depends. Drug level monitoring. So here, therapeutic drug monitoring. That's very much important in serum level drug concentration measurements. So important to minimize drug toxicity. Given high dose, we can streamline or optimize the dose. Vancomycin, we often use trough level. After fifth dose onwards, like 4 to 5 dose onwards, aminoglycoside, we often do peak. For that, we use hard-fork nomogram. Mind you, if it is applicable, following 6 hours to 14 hours of administration of particular antibiotic, that is either gentamicin or amikacin. If it is used for amikacin, we have to use the half. We have to half the value, divide by 2 and apply. For example, imagine we have given gentamicin 5 milligram per kg or maybe 6.5 milligram per kg at 8 a.m. Our dose is daily. Then at 2 p.m., 3 p.m., we have measured the value and it came as 6. So next dose, we can give 24 hourly. If value is 10, we have to think and we have to give 36 hourly rather giving for 24 hourly. So we have to do side. Then amphotericin B, voriconazole, all we have to do the therapeutic drug monitoring, no measurements. Adverse effect monitoring, always we have to think dose related, is it acute renal failure. So baseline serum creatinine is very much important if we are giving nephrotoxic antibiotic, acute hepatic damage, liver function test, myelosuppressors like cotrimoxazole use. WBC-DC is very much important, as well as it may be leads to Clostridium difficile infection. Other thing is administration method related. If we are giving higher, faster dose, Redman syndrome development is high. Or renal failure. If we give conventional amphotericin compared to liposomal amphotericin, patients' risk of developing is there. And we often administration method means we have to give pre and post dose hydration using normal saline. So exclusion of true allergies is also very much important. If penicillin allergy, there are in all population 1% in nature, but we often falsely categorize them as 8%. Like you think it's high, so we have to go for alternative therapies. But penicillin, mind you, even our primitive drug, I would say not primitive, our first miracle drug, it's still penicillin has having mortality advantage compared to other alternatives. That means for the similar condition, if you use penicillin and compare to other non-beta-lactam drug, cure rate is very much high and side effects and adverse effects are less in a penicillin non-sensitive person. So it is top higher compared to alternative drug. Clinical history and investigations, major and minor component detection assay is very much important. About the follow-up, sorry, IV to oral switch. So other thing is ideal for chloramphenicol, clindamycin, metronidazole, Cotrin, fluconazole, itraconazole, voriconazole. Yeah, there are companion drugs are available. IV counterpart to oral. So with clinical response in 2 to 4 days. In hand with inflammatory markers, we can give 80% if inflammatory markers from baseline to day 2. If it is reduction is 80% or baseline to day 4, reduction is 80%, we can go for the oral options while discharging the patient. Follow bacterial clearance, Staph aureus bacteremia. So we often do repeat blood culture 72 hours following initiation of anti-Staphylococcus aureus antibiotics. If patient is having urinary tract infection, culture positive, we often defy urine culture. And also we do with the follow up with the C-reactive protein of PCT. If patient is having chronic infections or patient who requires prolonged antibiotics, we often monitor with erythrocyte sedimentation rate ESR with CRP combination. So if patient have mucormycosis, we often do FES, weekly FES study for histopathology and fungal culture. So there is a role of outpatient parenteral antimicrobial therapy as well. Reasons for failure, except antibiotic failure. So wrong diagnosis, persistence of inflammation, complications, maybe pneumonia leading to abscess or pleural effusion, inadequate source control. Source is if think abscess, while even give proper antibiotic, it won't reach because it has a capsule. So if we're in a foreign body, we have to remove those. Source reduction is very much important. If chemotherapy in febrile neutropenics, we have to optimize. So overall, this is the what you want to know. So here you can see antibiotic therapy. We often give 48 to 72 hours. In febrile neutropenia, we often monitor in 72 hours. Like usual condition, we often with 48 hours. Clinical and organ improvement, oxygenation, hemodynamics, and organ dysfunction. If it is yes, we can de-escalate based on clinical microbiological data. Treatment duration based on microbiological result or biomarkers. While no, we have to think culture positive, adjust antibacterial, adjust PK/PD parameters, therapeutic drug monitoring, source control. If it is culture negative, optimize empiric therapy, search for other sites of infection. We go higher investigations, CT, MRI, even PET scan, complications, source control. Is it wrong diagnosis? May have in other complications like thrombosis or allergy. You still know what are the reasons for failure. We have to exclude. We have to think. Thank you.